Very nice. Yeah, the subtext is, what they call it, jack of all trades, but master of none, perhaps. Too busy doing too many things. But it's a pleasure to be here. It's an interesting sandwich, I guess, of talks here. We just had that surgical talk with deep brain stimulation, and then another kind of stimulation sort of through the skin and the acupuncture. And I'm going to talk about, or I was asked to talk about, non-invasive neurostimulation. So this is, I guess it kind of does fit into that category of in some way. And some of these slides, it'll be quick because some of the slides were presented by our neurosurgeon in her talk just a little bit ago. So as we mentioned, the deep brain stimulation, is this option that is available for our more severe affected individuals with blepharospasm, other dystonias. And that you saw her talk about the data that show that there is good relief, and we kind of quote roughly with our group about 50%. And this is hard because there's so many different, there's not great ways, and maybe Dr. Peterson will talk about in his talk, that our ability to rate your symptoms, to look at you, and say, you're a 5, right? When you know that, like, today you're a 2, yesterday you were an 8, you're like, there's so many, lots of things change, and how can I just put a single number to your condition? So there's some caveats, but it does seem to be helpful. And don't bother reading all this analysis, but this was also brought up. There's 233 subjects in this, what we call a meta-analysis. This is when they look at a bunch of other studies, because each individual study only has like 1 patient or 10 patients, 22 at the most in this study. But then if you put them all together, you get 233 people, and you saw the breakdown before about blepharospasm and those who had Meniere's syndrome. And overall, the different ways they could be analyzed. So in her slides, she had probably a little bit more, showed a greater benefit than overall. When you look at the scales, there was roughly about a 60% in the dystonia and about 50-some% in the disability. These are rating scales that we use to sort of assess how people do. So that's not bad, but it's like a decrease in those symptoms and disability by 50 to 60%. That's pretty decent. And so you heard about that. So we know this. Deep brain stimulation works. We know that we put these electrodes into the brain and we alter brain circuits. Okay, so your brain is connected and we're just putting an electrode in one place, but it has effects all through the brain because your brain is tightly connected in important regions. And so we call these networks the way the brain is connected, and the deep brain stimulation alters that. Okay, the downside though, right? There's always a downside. Individual results may vary. So this is true with every intervention, whether it's botulinum toxin or deep brain stimulation. And so those are averages that we're telling you about, right? So 50, 60% on average. So some had 10 to 20% not responders. Some had 80 to 90 great responders. And there are a few things that tend to show a good prognosis or a good response, and those can be things that aren't usually common in blepharospasm. So, genetic forms, right? Most of you have probably not found a genetic cause for your dystonia. But anyway, so that's the other thing, is that it is invasive, and so you do have that electrode, even though it's very small. There's still something going into your brain, and there's that wire that goes down to the pacemaker device, and they can get infected. They can have other problems that happen with them. And so another thing that I did a long time ago working in San Francisco was the neurosurgeons there was saying, when I'm implanting patients with dystonia, they seem to be becoming Parkinsonian. And so I was fortunate that I was able to be one of the first person to write this. This is their observations, but I got to write it up, and it's been very well established now over the years that the problem, we might be able to really treat the dystonia, but we're causing you a new disorder and making you slow and have more Parkinson's-like symptoms. So So it's not a perfect treatment, but it can be very helpful when needed. But wouldn't it be nice if we could just do something without like sticking an electrode in you that sort of did the same type of thing, right? So something less invasive. And so something you've probably heard about, and I'll go through some of these terms, but there's one thing that people will say was transcranial magnetic stimulation. There's been a lot of polling of the audience. I know we have like the chi and the liver. Anyone say who knows or heard about transcranial magnetic stimulation? Good, yeah. Great. So so trans means across cranium, so across the cranium, so it's not invasive, it's not going into the brain. And then we have magnetic stimulation. So in this case, they make a bunch of electrons go around in a circle and they create a magnetic field, and then they use that magnetic field to go across the cranium and stimulate regions of the brain. And when they do that, they can cause you can actually like induce a temporary stroke in someone, or you can excite those areas too. So you can kind of excite brain or decrease it. And this has actually been shown to be helpful in a number of neuro and psychiatric conditions, and has gotten FDA permits to do this, and it's actually available as a therapy. So people with depression especially can have this done as an outpatient basis. They go in, have TMS done, leave, come back. I think it's a couple weeks of therapy, if not more, if anyone's had it. And this can be helpful for depression. They've also, for migraine, for obsessive compulsive disorder, for smoking cessation, bipolar, anxiety. So it seems to be helpful enough that it's certainly safe enough that the FDA has said you can go ahead and use this. It's a little nuanced, but just so you know, sometimes the FDA just is approving the technique and not necessarily endorsing that it's actually effective. So you have to go elsewhere for that. But just be aware that when the FDA has a device permit, that just means it's okay because it's safe enough to use. It does not mean that it's effective. But there is a fair number of studies that show it seems to be fairly effective in these conditions. Now this might look a little overwhelming, but it's hard to talk about these techniques because it's not just simply sticking a magnetic stimulator up to your cranium and pushing the green button. So we have to decide, well, what are we going to target? What are we stimulating, or what are we not? Are we trying to reduce the activity? Do we do it like every second for a minute? Do we just do it really fast for a longer time? So there's lots of settings and parameters that we have to decide. What do we, how do we want the stimulation to go during a session? And then you have to think about okay, well, do I want you to come back 3 times in a day and get this, or, for a week, or do you just come every day for a month? So there's lots of ways that these techniques, we have to figure out, what works best. And so it takes a long time. So, this is approved for depression in 2009. So we're already 16 years later, right? I was where's the treatment for dystonia? Well, someone has to be able to do the studies, figure out how we're going to set this up, how we're going to test it. You get all this money, you do all these tests, and then you realize at the end of the 4 years, you're like, oh, we should have done 1 hertz, not 10 hertz. And so, it can be a very challenging area. So, but that hasn't stopped people, right? So people have done this in blepharospasm. And this came out of Mark Hallett's lab. This is 2010, so it's a 15-year-old study. And they looked at using this, what's called repetitive TMS. And so they had a hypothesis in terms of what kind of stimulation settings to do, and they did it repetitively for 15 minutes. And they showed that it improved symptoms in blepharospasm. So that was promising. And then if you look at the literature, it's not for 8 more years before you see another paper that deals straight with blepharospasm in this condition. But then they did it for 2 weeks. So this is what I was mentioning. So now they said, okay, let's do a little bit longer term with the same kind of stimulation, but also acknowledging that most those with blepharospasm are getting botulinum toxin injections. And so they did it after botulinum toxin, and then noted that those who had gotten the stimulation had improvement during the 2 weeks after the stimulation compared to those who did not have the stimulation, but by 6 weeks that was gone. So that's one of the other problems that comes up is like we stimulate your brain, and you might have benefit, good effects, but you take it away and then it just goes away. So the deep brain stimulation was, I think you asked the question, is it on all the time? Yeah, those things are on all the time, 24/7. So that's a different situation. So how do we adapt outside of something that goes transcranial, that you're getting as much stimulation or as potent or directed as deep brain stimulation, because it's on all the time. So that's in... So then there was a third study, so to not lose hope, people are still working on this and are still publishing on the results. And this one was also a repetitive transcranial magnetic stimulation in those who had blepharospasm and were getting injections with botulinum toxin, but were also who had anxiety and depression. So as I noted before, there seems to be good evidence that it helps with depression, and so they looked at how it might affect emotional states like anxiety and depression in the blepharospasm patients. And they did it with 20-minute sessions, so every day, 20 minutes. Actually, not every day. These are, like tumors only grow Monday through Friday, so you get cancer treatment then. Blepharospasm only bothers you during the week, so they would come Monday through Friday, and they would get 20 minutes of this TMS, and that was over 20 days. And so in 35 patients, so a pretty good size study with anxiety and depression, and compared to 28 where they followed them and they did something called sham stimulation. And so there was improvement, which is true, but a good amount of improvement comes from the toxin. And so we were mentioning before, like when you have deep brain stimulation, when you have more severe, you tend to do better, right? So if I were to go from 10 to 5, that's 50% improvement. Well, 4 to 2 is like a 50% improvement as well on a scale, but those may not seem as significant of a change because you've only moved 2 on the scale rather than 5, if that makes sense. And so so while there was improvement, it was not a lot of improvement, if that makes sense. So significant, but not a whole lot. And there was, though, about a 4-week prolongation in the effects of the toxin, which that's nothing to, shake a stick at, if that's the right expression. It's nothing to, that's pretty good because a lot of you are getting benefit from botulinum, but insurance is fighting it. It's lasting only 8 weeks, and so you suffer mightily for 4 weeks until your next injections or more. And so if we can find an adjunct, that might actually be helpful, right? So if you can get a little stimulation in between, that might help it last longer. So what's wrong with TMS, right? What's the problem with it? Well, one thing is, here's a nice little cartoon here. I don't know if you can see the mouse on there. It's pretty small. But anyway, it's got a big device. It's like plugged in the wall. It uses a lot of electricity. You got to come in there. You got to line it up. You have to have a brain MRI so you can say where's the part of the brain that you want to stimulate, and it's got to focus on there. And so it's not like you can take that home, and I imagine you're going to get pretty tired with the traffic going over to UCSD here to get your stimulation for 20 minutes. It takes you 4 times as long just to get there, and then you have 20 minutes of stimulation. So it's just not the easiest to adopt. So even if it did work, how are we going to get you to do that at home, right? So the other thing is that it's not clear what it's doing to the brain. So if we had more ideas, or we had a better understanding of what it does, and then we also had a better understanding of what's the problem in BLEF in the brain? Is there an area that's really hyperactive? Then we could marry those two and be much more effective. But right now we're not entirely sure about how it's changing the brain activity. And then there's variable responses and how long it lasts, and it seems to wear off quickly for everyone, so 2 weeks in that last study. And then there's some adverse effects that kind of limit its use. So what else could we use? If it's not magnetism, electricity. All right, good. So yeah, the other option is electricity. So this is a battery, right? And a battery is actually a little bit of electricity in there, and it's powering that light bulb. Well, if you have a battery and you put 2 electrodes, and these things called sponge electrodes, because they're actual sponges, this is real, then you can create what's called a electrical stimulation. So transcranial, again, electrical stimulation. And I don't know if you've looked at this, but on Amazon, there are several models out there for sale, and you can buy this. And this is generally marketed for migraine, which is probably why most of the models are younger women who more often have migraines. But these are essentially electrical stimulation techniques, and this one they have this frontal sort of targeting, and these people tend to feel that it helps them. So the question is, well, what about something like transcranial electrical stimulation for blepharospasm, right? Well, it goes back to what kind of electrical stimulation? So there turns out to be 2 main types. One's called direct current stimulation, and one's called alternating current stimulation. So kind of like the outlet, it's alternating current here. There was a battle between the direct and alternating currents. So which one? Well, I'm not sure, but I can report at least people have tried the direct current stimulation in blepharospasm. And so, again, this is 2016, so it's about 9 years ago, where there's a report about using direct current stimulation for those with benign essential blepharospasm. But again, it's interesting because it says 4 patients, but then it says a case report, not like a case series. So in this case, it's just a single case. And this other one that came out 2020, so about 4 years later, also looked at stimulation, and this time they targeted the cerebellum, the back part of the brain, but it was also a case report. And so, there's different hierarchy of evidence. And so, unfortunately, when you have a case report, it's like they do really well because everyone knows they're getting stimulation. There's a lot of attention paid to this person. And so, yes, it did help, but it's also hard to know how much to trust the evidence because it's the type that it is. So another possibility is alternating current stimulation. And so if you think about this, how can, the alternating current is kind of like that. The current is going like this, and you have these 2 electrodes, they're sponges, and you put the sponges kind of over the brain, and there's very low amperage current going back and forth through those sponges. And what I like about it is that it's not that it stimulates the brain cells. So in that magnetic stimulation, that actually either stuns them so they stop activating, or it enhances the activation. And alternating current, because the brain actually works, it has electricity and it has neurotransmitters, right? So it's a neurochemical kind of balance in the brain. Well, the brain cells firing, you can kind of encourage them to fire more or make them less likely to fire based on current going through them. So I won't get too much into the technical details, but we think that in blepharospasm, like other dystonias, that the brain is overactive, right? And the overactivity causes the excess muscle contractions that are experienced. Apraxia is a different situation, although there's some thought that even apraxia of eyelid opening might be an overactivation of a different place, with different muscles. However, so overactivation, so the brain is probably overactive. And so what might work best is if we can get those brain cells to fire less. I talked too long on myself on the slide. Got too excited. Let's see. So with the alternating current stimulation, it's on my screen. I don't know. Oh, no. Okay. Okay, good. It's kind of doing this little dance up here. I don't know if it's on my screen. I'll just talk with a lot of animation for the rest of it. Oh, there we go. Okay, I like the pretty colors. So there's been studies that showed that if the current stimulation was at 15 hertz, that made the brain cells reduce their firing, and so you could suppress their firing, so that might be helpful for blepharospasm. So this is, so then I went ahead and asked for money, and I got money from the University of Colorado, where I was at the time, the benign essential blepharospasm, as well as a philanthropic donor to study this. So we said, okay, this is 15 hertz, it can suppress the activity, let's put it over the sensory motor cortex, right? So the motor cortex is what goes from there, it goes to your muscles, it goes to your face muscles, and in this area by here is about where your facial muscles are. So you could just put the electrodes right there, we'll do alternating current, and we'll see what happens. We'll see if that helps. Well, I had tried to get money to do this study, and people said, how do you even know it's like crossing the brain? Like, how do you even know? Like, you're sticking a 9-volt battery, electrodes. They sell this stuff on Amazon, but has anyone like showed that it does things inside the brain? So part of the study that I did was to try to find out, like, could I detect any changes in the brain with the stimulation? And so put them in a brain scanner, an fMRI, stimulated them for 20 minutes. We could take a scan, but like what we call a functional MRI scan before, during, and after the stimulation. And we do it with this fancy, they put on I don't know, what do you call this thing, a helmet type of thing, and then go into the brain scanner with it. And there's different kinds of scans, but you could see brain flow changed with this device on during stimulation. This is a particular type of brain scan where you can actually look at blood flow. And if you see over here in the where there's this red spot, the cerebellum, and it diminished. So that's like you're stimulating here, and then it's changing the blood flow over here. So I'm like, I think it could be doing something to the brain. So that was exciting. And then there's some other connections here. This looks at the brain activity, the brain its connectivity. And so we're sending in 15 hertz stimulation into the brain, and you can actually see that the brain cortex is starting to like harmonize and activate with that. But you can't just do it on a single person. So we looked at it with about 10 folks with blepharospasm, 10 who don't have dystonia, and then 10 with cervical dystonia. And so about to report this has taken a lot of years. There was COVID, there was moving, various things. So it was a big project that's been through a number of delays. And I wish I had more to show you, but what I could say is that when we stimulated those with blepharospasm, well, before we stimulated them, there's some changes, so some activity changes in the brain that were increased in the sensory motor area that we were stimulating. And when we stimulated them, they became no different than the controls. So in other words, it might be working to normalize the abnormal circuit in the brain. So I think this is really exciting, it's really promising, is if we can normalize the brain activity, that could be a potential treatment. And the advantage of electrical stimulation is that you could wear this at night, perhaps, stick on a thing overnight, and you could do it at home. You wouldn't have to have that big device or go to your local TMS site and shop and get stimulated. So I think it has potential, looking to get this out there. The one downside is we did a test where we looked at them for 5 days in a row, and we did the stimulation. And I don't have all that formally analyzed, but there was no change. But do know that I only had 10 people in the study, and so it's hard to find changes when there's a lot of variability. So anyway, something that's promising. You could see that even, it's been going on since, what was the first study? I think 2009. It's been 15 years, right? So you're going to see more of this, I think, as we move forward, and it's exciting, but it's going to be a slow process too. So, and I think that's the end of my talk. Other than saying that we found that it sort of normalized the abnormal brain activity, and that it didn't have a change on symptoms. And then I just wanted to do a quick thank you to all of you, to everyone who participates in research, supports the BEBRF. I've mentioned to some people that they've funded another study that I'm actively doing now, looking at photophobia and blepharospasm, and they're, we couldn't do it with all you, so I appreciate that. And then I want to also have a heartfelt acknowledgement of my mentor, who who is Mark Hallett, who played a role early on here at the BEBRF. He was the medical advisory board director, I think, for like maybe 15, 20 years, something like that. And it's like 95 and 2000, 2005. He brought investigators from around the world to get together to talk about blepharospasm and really advance the work. He inspired me to go into dystonia research and has done a lot. And so this is a picture from our fellowship class. There was a lot of us. He had a lot of fellows. We were the best class, I always tell everyone. And it's amazing, like a family that he has sort of been a part of, that because of his interest in dystonia and blepharospasm, he's really created a lot of people. And he's, here we were at Aspen, where he would teach at what we call the Aspen course, and he's taking us out on a bike ride back day. So this is us all meeting in Hong Kong, and just all the people who were at that meeting who would come out and support him. And this is a DMRF meeting. Many of these people you probably might be familiar with, but this is just a little bit over a year ago. And he's gotten very ill, so he won't be with us long, but he had a lot of influence. And I just want to say one of the things he did is back in 2016, I hosted this, just like Dr. Peterson, in Denver. And so it was the 40th year anniversary of the BERF. And this Mark Hallett on the side with Mary Lou and Joe Jankovic and a younger beardless me. And it was a really great experience. I hope you've been having a great experience with it. We had, we have such great people on this side as well as on your side coming here, and I appreciate everything, and thank you. So.